question is, how long will that take to occur? Is there going to be a robust enrollment of that population in this community? Blue Cross Blue Shield of Texas, it's called, Cindy, what is the program called? George just told us today, but just announced in Sunday's Dallas Morning News that they now have providers in all 254 counties of the state of Texas to roll out this fall product that will be available to be purchased on the open market for those who otherwise could not get insurance. So if in fact organizations like that are robust in getting folks enrolled, we think the effects are not going to be as negative as they would be otherwise. The other key aspect of them not being negative is performance. A lot of the cuts that are going to come in 2014 and following are for those organizations who do not work effectively with their medical staffs to have outcomes that are in the top 25 percentile of the outcomes being benchmarked for particular types of care. If you're in the top 1/4 percentile, you're actually going to get a bonus. If you're in the middle 50th percentile, you have no ill effect. And if you're in the bottom 25th percentile, you have another adverse factor where you don't get as much money. So we think working proactively with the medical staff is going to be very, very important. The final thing that's going to be important that we believe, and Gary, and we're working with Gary and his staff actually in a presentation this Friday, is something called accountable care organizations. What role will your institution and your physicians play in someone's accountable care organization? The accountable care organization is easy to think about as an insurance company that effectively takes over the responsibility for total care for at least 5,000 covered lives. But you've got to have the deep pockets to be able to take over that care, and a number of organizations are entering into accountable care relationships. What we are advising Gary and his team and helping them to learn about is actually a statewide organization that will become an accountable care organization and will selectively contract with organizations across the state. We're on the ground floor of actually owning that statewide accountable care organization, introducing it to Lufkin this week, and that's another benefit that we would bring to your organization is the opportunity to participate. And I'm talking about an organization that is representative of the largest not-for-profit hospitals in the state, who will be looking for contracted community entities to play a part in their ACO. Cindy?
Just let me add that obviously with the changes that are going on, we've been doing a lot of medical staff education, a lot of board education. What is the Affordable Care Act? When do we need to be worried about different things? And really what our advice has been to hospitals, particularly in smaller communities, our advice has been you need to have your house in order because you need to be geographically essential. As some of these people who are contracting, you're probably not going to be big enough to have your own ACO, but you want to be the shining star that the ACO looks out and says, oh, the Crockett and surrounding areas, that's the hospital that we really want to contract with. So we really talk to medical staff and leadership to say, as efficient as possible, providing the best quality care that's already out there on hospitalcompare.com. How are you doing with your core measures, et cetera? So it's really get back to your blocking and tackling, if you will, from an operations standpoint.
And as Wilson and Gary pointed out, it's that quality outcome, it's at that most effective price or cost. You know, Gary's leadership and Wilson's support and our team's support took almost $20 million out of that organization's expense column and enhanced revenue in 1 year. So one of the first things that we would do if we were to enter into a relationship with you is what Cindy said, is do an ops assessment. What is it that you can do more efficiently, or what sources of revenue do you not currently have, that if you had the right doctors you could grow? How do we get those outcomes at the best possible level and those costs at the most appropriate level?
Let me add one thing to that, Mike, actually, what's things?
Our board wanted independent with what healthcare reform would be. And when I say independent from CHC in terms of, let's get another set of eyes on this, that's an objective. We engaged a firm to do that. Their first look back at the impact of healthcare reform on Memorial Health System is actually positive. It's accretive to earnings. And it, you know, we all know we're going to lose some on the Medicare side. The question is, what's made up on the public exchange, the insurance side, et cetera. And assuming that we can maintain market share, then we've got a payer mix that will benefit more from healthcare reform than it will hurt. Now, we've got to maintain market share, you know, in order to do that, because once those patients, nobody's been really competing with us for self-pay patients, but once they become insured, there'll be more competition, so we've got to maintain market share to do that. But there's several things that are real key in there, you know, that we've learned through CHC and the organizations that they can get us access to. And I'm going to come back to that piece in just a minute. And two of those, I think, have real impact here. I'm assuming that your payer mix is probably not going to be dissimilar to what ours is in Lufkin. And so, you know, you could think offhand that, you know, you might benefit positively from the additional insured patients that you've got. But that needs to be, you know, looked at. But you got to have a good primary care network, and you got to have essentiality, you know, that Cindy talked about. That's one thing I see when I look at Crockett is your reputation for your medical staff, you know, is well known. It's positive. You've got to cut above medical staff here for a community this size, and you've got a well-engaged group of primary care physicians, and that's going to be key, you know, to the accountable care world and just to everything that we've got to do going forward. And the other aspect I see about Crockett that you've got going for you is your geography. It's not changing anytime soon, and you're fairly isolated in terms of having a competitor, you know, right in your neighborhood. And so it's easy to look to see combination of your medical staff and your geography is really going to create an advantage for you to be in those accountable care organizations and succeed with it.
I looked at my email to find the Blue Cross Blue Shield program. It's called Be Covered Texas. It rolls out this weekend, and they're estimating that there will be between 1.3 and 3.1 million new lives covered by Be Covered Texas, which is the Blue Cross of Texas response to the mandate for a state exchange. And that's going to be available this fall. Yes, sir. Question?
Now, I'm just going to go back. You intrigued me with the state-run ACO. That would not be a centralized ACO. That would be actually, it would encompass
Statewide.
Statewide would encompass the entire. So there would be many satellites coming off this ACO?
Absolutely. And if I could tell you today, the organizations that are active in its formation have already spent $2 million in understanding how to manage their own employees. And these organizations have 20,000 employees. That's the learning curve. If I could tell you where they are, you would appreciate how state-focused it is. But they're not everywhere. So they're going to have to look to these geographic marketplaces and say, who else do we want to invite to play with us?
And it'll be made up of not-for-profit health systems.
Not-for-profit health systems around the state. Other questions?
I guess I'm going to ask all the questions tonight.
That's okay.
Tell me what your, obviously, as we said, we're going to compete for self-pay and no pay.
A lot of the percentage of healthcare is problematic, and of course, there's a large percentage of it in healthcare, especially in Houston County and in our surrounding reaches here. How do we look at managing that? How does that play into the picture for care to grow to the hospital? I know that's a tough question.
Well, it's a big question, and it will not happen independently. In other words, you as a district or you as a hospital organization will not be able to handle it by yourself. Some of the things that some of the organizations that are going to have to help you, have to help assist in handling it are business and industry. You know, one of the things we talk about is education of physicians and boards, but we have to also educate the businesses and industries relative to if in fact they provide coverage, what are those things that would enhance the healthiness of that population that's covered. You know, we've got to work with the schools, we've got to work particularly from an indigent population, what are the healthy aspects of education in the school setting, et cetera. And if in fact we do all that, we're still going to have a boatload of indigent patients. We're going to have to help educate them that the emergency room is not the most appropriate nor least expensive access to care. We're going to have to work with the city and county agencies in terms of outpatient settings or triaging those patients from the emergency room to some type of outpatient clinic or setting. We're going to have to work with medical staff, so a lot of physicians are not seeing those patients anymore. Being the hospital district, I don't think it's your mission not to provide access to care for that population. And I take my hat off and salute you for having that mission. But because that's your mission, we've got to work creatively together on all fronts to see how we can address access to care for those people. Certainly, the state insurance exchanges and the things that we can do will help and will perhaps allow more providers to get back engaged with seeing that patient population. Hopefully, some of the positive outcomes of the financial arena from that coverage would perhaps allow us to get more involved in rural health clinics or types of settings where in fact that patient population can be appropriately seen. And again, with no deference or no criticism intended to family practitioners, MDs, or DOs, I think we've got to look at physician extenders. What settings do we have appropriate practitioners or physician's assistants that are credentialed and appropriate under the direction of a family care provider to extend those services to that population? Not a simple answer, but it's something that we're not thinking about. We're going to have a big challenge. Any other questions? We are delighted that you would include us and having the opportunity to come and present to you this evening. We are ready to return and to talk with you in more detail about a specific proposal. We would think that as you begin your deliberations for the future, if we would get to a point where we would be considered, we would sign the confidentiality agreement and go through a due diligence process so that before you chose us, you would know very specifically what our intentions were, what our guarantees were, and how working together we could continue the commitment to the health of your community that you folks represent. So thank you for letting us speak.
Very timely. Good work.
Good.
Okay, we're down to the end of the agenda. We have a public comments from anyone. Communicate with us. Okay, there will not be an executive session this evening. So, no other business, we need to adjourn. Thank you.